You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes. You can also follow us on Twitter at ASAMorg and Facebook. Now, let's go beyond the abstract.
Hello and welcome to Addiction Medicine Beyond the Abstract. I'm your host, Dr. Shawn McNeil, and today we're joined by Dr. Michael Incze. He's a primary care and addiction medicine physician and an associate professor at the University of Utah. So Dr. Incze, thank you for joining us, and I would like to begin, as we typically do, by having you describe your journey into becoming an addiction medicine clinician and, just how you found yourself practicing in this field.
Wonderful. Thank you. My interest in working with people with substance use disorders really goes back to medical school. I went to med school at UC Davis and just had this amazing experience as a student helping to playing a small part in running a harm reduction focused medical clinic that provided free medical care and substance use disorder assessment and treatment and really harm reduction counseling to people who use drugs in the local area. And I just, got amazing mentorship there and really just grew to love working with the people that would come to the clinic week in and week out. Who showed up to take care of their health despite tremendous adversity and barriers to accessing medical care. And then I went as a resident, was in San Francisco at UCSF, and I got to do more work doing kind of street medicine outreach and just working with some of the luminaries in terms of substance use disorder treatment and just making substance use disorder treatment more accessible to vulnerable populations that worked there. So I really was lucky to get great teaching that kind of nurtured my innate interest there. And since I've been at the University of Utah, I've kind of hit the ground running and also have fantastic mentors and colleagues here that inspire me daily.
Very good. So this paper you've written discussed increasing the delivery of addiction treatment, specifically for opioid use disorder, in the primary care setting. Now, first of all, what gave you this idea? And second of all, what benefits are there to delivering this care in the primary care setting?
That's a great question. And I, my sort of first love in medicine is primary care. I'm a general internist and I really love primary care. And I just feel like there are so many great tie-ins between the attributes of a good primary care doctor and just sort of the structure of contemporary primary care and what it takes to provide good opioid use disorder treatment. So from a patient perspective, I think one of the things that came up in our interviews was that people just really loved developing a longitudinal trusting relationship with somebody that they feel like they could open up to and build trust in over time, and not just one person really, but like a clinical team, so the front desk staff and the nurses that work in our clinic and the medical assistants and the social workers, over time, patients really developed a relationship with the whole care team. And I feel like that was a lot different than the sort of quote unquote revolving door that they've experienced, maybe accessing care in acute care settings like the emergency room or urgent cares or even like substance use disorder treatment programs. And the other big thing is just, being able to feel like substance use disorder is just like one aspect of their overall health and not just this separate defining characteristic, that oftentimes is kind of imbued with stigma and shame and things like that. So there was just a lot of feedback that we've gotten about how, hey, let's talk about this for some portion of our medical visit, but how about, your healthcare maintenance and your vaccines, and how about, the diabetes that you also have, or your blood pressure that, nobody's addressed in 15 years. They've just sort of told you that you have it and not done anything about it, So I think patients appreciate that. And I think, from a provider perspective, there's just, in primary care, we care for a lot of chronic disease, right? And not much of it gets better. We manage it, but it's hard to see improve, like major quality of life improvements, in the managing diabetes or, chronic obstructive pulmonary disease or things like that, heart failure. I feel like people with substance use disorders, certainly there's challenges, and certainly there is, some the full range of emotions, including a lot of sadness sometimes when things don't go well. But I also think that people get better quickly and accumulate, just like experience tremendous, functional and quality of life gains that you just get to celebrate. And so I think primary care doctors don't get a lot of that in their day. And so when I talk to PCPs who initially are reticent about providing addiction treatment or OUD care and who start to dabble a little bit, I just find that, they really love it, and the same skills that, lead to good primary care, which is humility, a spirit of inquiry, curiosity, really lend themselves to good addiction treatment too.
All right. And do you feel like coupling these services, primary care with addiction treatment, do you feel like this increases the overall health of this population?
I do. I truly believe that. And, there is another aspect of it, which is just that, we have huge deficits in OUD in particular, but substance use disorder treatment in general in, this country. And I just feel like primary care is kind of like the sleeping giant, it has such a vast reach and such skillful clinicians. But, the most cited study on this, I think, says that, as few as 10% of PCPs prescribe medications for opioid use disorder. And, that's something that I really think could greatly expand access to treatment if we were able to just build OUD care into more of a routine part of primary care.
Okay. Now, do you feel like there were any barriers that the subjects in this study experienced throughout the course of receiving their treatment that were unique to this population?
Yeah, lots of them. And I think part of the reason that primary care is great, and that having an interdisciplinary care team and not just a single provider is important, is that, you do your best to overcome those barriers. For example, people don't show up for appointments because, their transportation fell through, or they didn't have money for the bus, or they have competing responsibilities that they didn't realize. And, I think in some primary care environments, and many really, it's just the schedules are packed, and if you miss your appointment, well, boy, you're kind of out of luck. Good luck. Our next opening is with somebody else in 3 weeks. So I think having a kind of an interdisciplinary team in primary care and really getting everyone involved, the clinical pharmacists, the care managers, a kind of a modern primary care team is really important, because it really allowed us to kind of quickly swoop in, reach out to the patients, switch their visit to a virtual one if they needed one, or, just arrange for rapid access to care to prevent people from falling through the cracks.
Okay. And did you ever contemplate integrating these services into other types of clinics, like infectious disease or perhaps like a mental health clinic?
Yeah, definitely. Well, I feel like, for mental health, I think there have been kind of carve out clinics within psychiatry for substance use disorder for some time, and we have those at our university, and those exist. And I do think better integration, there seems to be sometimes, just anecdotally based on my solitary experience, a little bit of a dividing line between the kind of addiction psychiatry and addiction medicine worlds. But I think that certainly they do great work. And then in terms of other specialty clinics, we work together with our infectious disease colleagues, and we have a collaboration with our pulmonary hypertension clinic to sort of share care with them. Hepatology in terms of people who are on the liver transplant list, for example, who need additional support with substance use treatment. I think those are all great partnerships, because those patients all need primary care too.
All right. So the next question I had was about the study itself. I believe there were 21 subjects initially, and I think 14 of them finished the entire process, including the final interview. It does look like some of them had some comorbidities, so it probably benefited them to be seen by primary care. So with this improved engagement in care, were there indications that they were better treated than patients not seen in a primary care setting?
I would say that primary care may not be like the right environment for every single person with a substance use disorder, right? They exist on a spectrum, and we do have people, for example, that benefit from like residential treatment for a little while, just because perhaps their needs surpass what we can offer, like in a primary care infrastructure, where we're not able to necessarily like see people for an hour every day, or like an intensive outpatient program, or sometimes patients who really just truly face just tremendous barriers to accessing primary care, where you still do need to, somewhat be able to show up at a specific time for an appointment. I mean, we have a lot of flexibility in our clinic for that, but we don't operate on a totally like a walk-in basis. So having other options in the community that can accommodate folks, mobile vans and like clinics with better walk-in availability that are co-located with other services that people that face barriers to accessing care use. Those are all like important parts of kind of a comprehensive approach to making sure people get care. And then you can certainly like push in primary care services to things like opioid treatment programs, where people go every day or frequently at least to dose methadone. Why not integrate primary care services there too? So I think there's a lot of different ways you can do it, but I think either way you add it up, integrating regular medical care with substance use disorder treatment is hugely helpful, and not feeling like, when a patient comes to show up to get their healthcare, that they have to say, well, you can, where they hear something like, you can get this aspect of your healthcare treated here, but not these other aspects. You're going to have to make another appointment and go somewhere else for that. Oftentimes I think that just doesn't happen, so.
Good. So it looks like the main services that they received were primarily medication management. Did you contemplate adding other services like counseling into their treatment regimen?
Yeah, we, since we wrote this paper, we've started, group visits and integrated peer support services and, a contingency management program into our clinic. So there's lots of different things to do, and certainly medications are important, and, probably the most evidence-based treatment we have for opioid use disorder. But, that doesn't mean that it's not good to offer a range of services to folks. And, we have some patients that just ardently like look forward to our group, and our peer support specialists, our peer navigators are just like incredible. And yeah, we're really grateful to have like multiple disciplines. We have essentially like a nurse-led program now, based on kind of a Boston Medical Center approach. And so I just really believe, that having like leveraging all disciplines within primary care is really like how you harness the true power of primary care to help patients.
Yeah, and I'm pretty curious too what your anecdotal feedback was from some of the study participants, particularly in regards to how they enjoyed the team-based model and the integrated services.
Yeah, it is one of our it was one of our like themes that we talk about in the study. And so yeah, just as I have the paper in front of me, I'll just read a quote. It's the participant said, "I just feel like whatever issues are going on, they're all working together to help me do better with my diabetes and the addiction itself. So it's nice to have them, even when I'm not there, they're talking to each other how to solve issues and get stuff done." And in our particular clinic, just sort of by chance, we are co-located with endocrinology. We sort of like share a clinic hallway, and so for this particular person that needed perhaps specialist support for diabetes, or anybody that would need that specialist support, it's even like extra convenient to even have the specialists co-located in a lot of patient-centered medical homes, and even FQHCs like have more integrated specialty care now, especially like mental health care. And so I do think that's awesome. That's like the ultimate, right? When not only can their primary care team coordinate with each other, but also when they can be on the same page with any specialists they may need to see, and things like that. So I do think the team-based care matters a lot. And yeah, shout out to our medical assistants and nurse care managers and clinical pharmacists who really like work so hard. They're like the glue that holds the care that we provide together, because when patients don't show up for an appointment or something happens and they fall out of care, it's like instantly we have people calling them and really like trying to do outreach and trying to like loop them back in and do some sort of contingency planning. And I should just point out, like, none of these folks were specially hired to do this or have any like addiction training. I mean, I'm addiction medicine certified, but none of our interdisciplinary staff are. They just do this. They just work in our primary care clinic and have really like taken this on to provide excellent care to this group.
All right. Well, this is good, and that's all the prepared questions that I had. I do want to ask if there's anything else that you wanted to bring up that might be helpful to our listeners.
Yeah, I guess if I just had one other thing to add, it would just be, that a lot of PCPs are initially reticent to adopt addiction treatment or OUD treatment into their, scope of practice. And I get it, like many of them have never received any training on how to do this. Primary care physicians are already, overworked and, really subject to inbox management that never stops and, can just feel like one more thing. And so I think, for people who may be listening to this podcast who probably are already, addiction medicine trained, addiction medicine enthusiastic at least, just really being there as mentors for your colleagues and, encouraging them to rather than refer that addiction treatment out, to really work with, local mentors and local champions to start treating patients, even just, one by one. I just feel like almost every single time, I would say every time personally, I've seen that happen. The PCPs and the patients have both really been so happy that they made that choice to do that care together. So really enthusiastic about more PCPs doing this work.
All right. Well, this has been a fantastic discussion. Thank you for your insights into the work that you've been doing, and thank you for being on the podcast.
Yeah, well, thank you for a great interview and for having me and allowing me to talk about this.
Dr. Ince's article can be found in the July-August 2023 issue of the Journal of Addiction Medicine. Thank you for listening.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.